this concept of silent hypoxia, happy hypoxia. What do you think about that, David?
So it's been a concept that I've read about, seen many times, and the hardest thing about it is just wrapping your brain around how you can have a patient who's satting 83%, doesn't look normal, but man, they just don't look that bad. Like their SAT is really discordant with their overall gestalt clinical presentation. Like, yeah, they're clearly not, they're at their baseline, but their SAT is not reflective of how you would just look at them. Like if you didn't see that number, you would never guess that. And so, I'm kind of a believer in it's sort of colloquially called the happy hypoxemics. And I will admit, I don't know how happy the patient was, but they were very tolerant of it. And by other measures of perfusion and oxygen delivery, like something as basic as a lactate, they seemed to tolerate it like pretty well and didn't have physiological sequela that I was having to intervene for. So it wasn't just, hey, they're really this hypoxic and they're suffering, but don't seem to be manifesting in a respiratory distress for whatever reason. It seems like their bodies were able to utilize the available oxygen in an effective manner, and were able to perfuse their tissues and have normal metabolism without too much drama. But I guess the biggest part of it was just because it really goes against everything you've ever been taught or ever seen. Normally, if you have a patient who's consistently satting 85, they have a lot of subjective dyspnea. They are working to breathe. Their presentation is reflective in what that SAT is. Like it all goes together, and you just have to put that number away and accept that I'm going to look at the patient. I'm going to ask them about how subjectively dyspneic they are. I'm going to monitor their work of breathing, and I'll monitor other lab work. And I will personally, if someone's tolerating that on high flow, I will tolerate SATs in the 80s for quite some time. And when I see the patient requiring more time on non-invasive, kind of my general thing is like for intubation, it's okay if they can wear non-invasive at night and do high flow during the day. But as they start to need more and more time on the non-invasive mask, then I'm more concerned that they're going to acutely deteriorate. And obviously, you never want to wait until someone's in extremis to pull the trigger to intubate somebody. So that's sort of been my personal threshold. But it has been the biggest thing of just educating myself and my nursing staff and my other ancillary care providers that you can't just look at that pulse oximetry. You have to look at the entire patient and the big picture.